Cholesterol medications. Most people think of statins. But what if I told you there are new drugs that work better, are safer for some people, and even go places statins can't? Today, we are diving deep into the next generation of cholesterol-lowering medications. What they are, how they work, and who might benefit from them. Hello, this is Dr. Nony, and this is your Power Lab, where we crush health myths with science and make complex medicine easy to understand. So let's get started. First of all, cholesterol basics. Let's take it back to the basics, right? Cholesterol is not bad. In fact, your body needs it to make cells, hormones, and vitamin D. But when there is too much of the wrong kind, it starts to clog your arteries, like grease in a kitchen pipe. We have two main kinds of cholesterol. Number one is LDL, low-density lipoprotein, or called lousy or bad cholesterol. And number two is HDL, high-density lipoprotein, or helpful or good cholesterol. When you have high LDL, this can lead to plaque buildup, inflammation in the arteries, and increase your risk for heart attacks and strokes. That's why doctors usually aim for LDL less than 70 mg per deciliter, especially in people with heart disease or high risk. Let's talk about our old medication, statins. Statins have been around since the 1980s. They work by blocking an enzyme in your liver that helps produce cholesterol. We have some common kinds of statins. Number one is atorvastatin, or called Lipitor. Number two is rosuvastatin, which is called Crestor. And number three is simvastatin, which is called Zocor. The benefit of statin is clear. It reduces LDL by 30 to 50%. It lowers your risk for heart attack, strokes, and death. And they are well studied and inexpensive. But here's the problem with statins. Some people don't tolerate statins well, with side effects like muscle aches, fatigue, and brain fog. And others don't reach target LDL. That's why some people just stop taking them. That means low compliance. That's where new drugs come in, and they are fascinating. Let's talk about the PCSK9 inhibitors. First of all, let's meet the PCSK9 protein, a natural blocker that makes your liver less efficient at removing LDL from your blood. PCSK9 inhibitor block that protein, allowing your liver to keep vacuuming up LDL more efficiently. We have two FDA-approved medications. The first one is Alirocumab, or Praluent, and number two is Evolocumab, which is Repatha. They can lower down your LDL by 60%. They work with or without statins and can lower down the risk of heart attacks and stroke. It can be injected every 2 to 4 weeks, and they are ideal for statin-intolerant patients, genetic high cholesterol like familial hypercholesterolemia, and very high risk patients who need aggressive LDL lowering maneuver. Let's talk about bempedoic acid, or Nexletol. This one is a pill, not an injection. Bempedoic acid works in the same pathway as statins, but is only activated in the liver, not in the muscle. That means fewer side effects like muscle pain. The good about this medication, it can lower down your LDL by 15 to 25%. And they are good for people with mild statin intolerance. And this patient has mild risk of gout or stomach discomfort and can be added as an adjunct to statins, or it can be used solo. Let's talk about Inclisiran, or Leqvio. This is where it gets really cool. Inclisiran is a gene silencing drug. It uses RNA technology to tell your body to produce less PCSK9 altogether. As far as dosing, you give 1 shot today, 1 shot at 3 months, and then just twice a year. The good thing about this medication, it can drop your LDL by 50% or even more. Simple schedule, well tolerated, and great for forgetful patients. It is still relatively new, but early data is strong. Now let's talk about something new, Lp(a), which is new drug called Pelacarsen. So here's something most people and even many doctors don't check. Lipoprotein A, or Lp(a) for short. It's a type of cholesterol particle that is sticky, inflammatory, and genetically inherited. 1 in 5 people have elevated Lp(a), and statins don't lower it all. So why does it matter? Because if someone has a high Lp(a), that means he has high risk of heart attack, strokes, and valve disease. You can have a perfect LDL, but still be high risk. The solution is a new drug called Pelacarsen. This medication is an antisense oligonucleotide. In a fancy term, meaning it turns off the production of Lp(a) in the liver. So it can lower down your Lp(a) up to 80% in early trials. This medication is still in phase 3 trials, but it is one of the most exciting breakthroughs in preventive cardiology. You might be a candidate for any of this medication if you have had a stroke or heart attack, if you have a very high LDL or familiar hypercholesterolemia, or you can't tolerate statins, or your LDL is still high even on statins, or you have high Lp(a). Please ask your primary care physician for blood tests. Most of these new drugs are used in high-risk patients, not necessarily for everyone, but they offer real hope when statins are not enough. We are living in a time where cholesterol treatment is no longer one size fits all. We have got shots, pills, and gene therapies, and tools to tailor treatment to your genetics, goals, and lifestyle. If you or someone you love is struggling with high cholesterol, had a heart event, or just wants to know their options, please send them this video. It could literally save a life. Again, this is your Dr. Nony from Power Lab, helping you make sense of science and make better choices for your health. Please subscribe, like, and hit that bell. And tell me in the comments below, have you heard of any of these drugs before? And would you ever switch from a statin? Waiting for your comment below. Thank you so much for listening, and I wish you a happy day. Thank you.